Hi, welcome to Imposter Syndrome. I am Elizabeth Hanna, your host, nurse practitioner, and guide to trying not to feel like you are faking it all the time, because I'm faking it all the time. So I'm pretty good, at least at trying not to feel like you're faking it all the time. Today, I wanted to talk to you about the different specialties in the nurse practitioner world. And this is in keeping with my theme for the next few weeks about applying to nurse practitioner school, because that's this time of year. And there's lots of pros and cons to choosing a specialty straight out the gate versus just doing FNP. I said in my first episode, I am actually an acute care nurse practitioner, adult gerontology acute care nurse practitioner, which is AGACNP. And then I actually went back and did my PMHNP, which is psychiatric mental health nurse practitioner. So I'm dual board certified, and I'm everything but FNP. And then I actually teach on an FNP program, so I'm like the least qualified to teach on an FNP program. No, that's not entirely true, because there's a lot of core classes that are similar, and I do teach also on a CRNA program. I teach informatics, so I feel like I'm pretty well positioned to talk about some of the advantages, disadvantages of specializing, and why you might want to consider specializing versus doing FNP specifically. So let's dive in. There are a lot of specialties. I have a notepad here in case you think, where's she looking? Because I didn't want to miss any, and I probably will miss some because I feel like there's a lot, and some of them are like subspecialties of specialties. The big ones that we hear about, of course, are FNP. And I think it's something about 70% of people decide to just go straight into family nurse practitioner. And the idea behind being a family nurse practitioner is that you would go into primary care. A lot of people that I know that do family nurse practitioner do not go into primary care. I should probably look into that data, and maybe I will, and then try to put it onto the show notes. So I'll look into that, make a little note right here. FNP2, PCP, pipeline. But that was kind of the idea behind it. And in fact, that'd be kind of an interesting show, is talk about how did family nurse practitioning, how did nurse practitioners come to be in the first place? And I do know a little bit about that. So that's kind of a fun thing to talk about. Because why does it exist here in America? Why not in other countries? Why have other countries adopted it? But the FNP idea is that you would go into primary care, of course, a shortage area, and that you're able to treat the whole entire lifespan, baby to geriatrics. It's nice because you can do everything. It's not nice because you might get kind of a broad brush approach to everything and then feel like you're really an imposter because you've only gotten a taste of everything. Also, one of the big challenges is, say you're really interested in pediatrics and I'm going to do pediatrics within primary care. You might find it really hard to get that pediatrics placement. You might also find that the training for psychiatric mental health is very paltry, and the reality is, if you do primary care, at least a third of what you're doing is going to be psychiatric mental health. But of course, that's what CME is for, is to go and then learn those things. I would say that's the biggest disadvantage, is that you're going to get like a smattering of everything, and you might feel like kind of like a jack of all trades, master of none. For me personally, why I didn't choose it was because I was a nurse at the Veterans Affairs. I was already dealing with fairly sick patients, because the Veterans Affairs, at least where I was in particular, and this is most of them, was kind of already a geriatric hospital. We had really old patients, and as a result, pretty sick patients. It was not uncommon to come in with like 30 medications, an equal number of comorbidities. And so the idea of then, and I worked in the ER a lot, and so the idea of going somewhere and then doing for clinicals just like swabs for strep and flu and kind of primary care stuff. Our ER, I think someone told me it was a trauma 5. I should look into that. Is that even a thing? I was like, I didn't know it went down that low. But we did do a lot of primary care because at that time, and I'm sure it's still the same, the primary care people were struggling to get people in, so we got a lot of that overload. So I'm like, I kind of get this already, and that sounded really boring to me. So I really wanted to do something more exciting for my clinicals. DNP is 3 years of your life, and I didn't have any ICU experience. I would go into the ICU to place lines, but I didn't have that. So I thought it sounded cooler to go and like learn about the ICU and to really take care of sick patients. I also loved med surg, and I loved rounding with the doctors and hearing what the internal medicine doctors did. I also worked nights and sometimes could go through and really pour through the notes, and I liked how the internal medicine doctors would organize their notes and really think about each problem and then have like a bullet list of we're doing this, 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 and this is how we're going to do it, and this is what we're going to watch for. I just thought it was neat. And so that was kind of why I chose acute care. And I did, even at that time, have this sort of debate between should I do acute care or psych, because also being at the Veterans Affairs, I saw a lot of psych. And being on float pool, every once in a while I got to go over to the psych unit, and it was always fun. Loved it. And I went and talked to somebody who was over in the psych unit who was a nurse practitioner, and I thought they were a PMHNP because they worked in the psych unit, and it turned out they were actually an acute care nurse practitioner. They got hired initially to set up a detox unit, like an alcohol detox unit on the psych unit, and they got hired, onboarded, and then the funding got pulled, and they were like, well, what are we going to do with you? Well, you have this acute care background. And so they basically made her the person who monitored all of the medical stuff for the psych people. So if somebody was sick, she could prescribe medications. If somebody needed meloxicam for their sore back, she would be in charge of that. So she took over that role. So when I went over there to talk to her, because I knew her since I was like a nursing student, I actually thought she was a psych provider. I'd done rounds with her, and I really had never realized that her role was medical. So she sat down and she said to me, look, you're always going to do psych no matter what you do in medicine. You're going to do psych one way or another. And she encouraged me to do the acute care because of kind of like the medical rigor of the course. So with FNP versus acute care, we all came in and did the same pharm class, health assessment class. What else was the same? It was kind of the first year was really similar. We were all in the same track where I went at the University of Utah. But then that next year, we got an extra pharmacology class. We got an extra, that was that pathophysiology class. So we had one extra one. The psych people had an extra one too, but it focused on neurobiology and like psychiatric medications. So if you're really into that, you're like, I really want to learn psychiatric meds. I really dig it. I really want to learn about the brain and pathophysiology of the brain and when things go wrong there, then I would say just go straight into the psych. And I actually didactic. I enjoyed the psych the most. I did enjoy a lot of the stuff with the acute care. In terms of the didactic, it was okay. What I enjoyed the most with my program, and this is program by program, to be fair, I think other programs, could have been better. I really loved our guest lecturers. I loved that. We got to have people from the transplant team, from the cancer team, from the nephrology, all these guest lecturers came, and I loved that. My favorite thing were the clinicals. They were so interesting. I loved being with nephrology. I loved being with the bone marrow transplant. I did a big rotation with that. I loved internal medicine. I loved all of those. I loved surgery. I did that with solid organ transplant. I did the burn unit. I did neuro ICU. I loved that. I was with the neuro ICU in a place that split neuro intensivists versus neurosurgery. So I just did neuro intensivists. Very fun. So I loved my placements. That was well worth it. When I did psych, I loved the didactic. I think so 70% do FNP, and then I think it's something like 14% do acute care, and I don't know how many are doing psych now. I don't know the breakdown exactly. The other thing that people do is CRNA. That's an incredibly competitive program, very rigorous. Usually you need to do a few more science classes in order to do that, like physics, chemistry. Don't let that put you off. If you have that ICU background, please consider that. If you are underrepresented in the CRNA world, please consider doing that. And that's all I'm going to say about that. I love my CRNA students. I love my CRNA students. They are inspiring and inspired. Teaching them is like drinking a cold glass of refreshing water when you are parched. I learn so much from them. They are fun, they are interesting, they're engaging. And I teach them informatics, which is, notoriously people don't want to know about this. It's boring to them. But they come at it fresh. They come at it with an open mind. And I'm really passionate about that. I think it's like a really neat subject. And so we have so much fun. I love teaching them. They're really cool people. And just my stereotype of like, are you a CRNA kind of person? If you on your downtime like to do rock climbing, paragliding, mountain biking, ultra marathoning, if you're like a go person, if you're really athletic, if you're that person on your ICU where you're like learning, you're like, I want that complicated patient who has the Swan-Ganz, the whatever, you're the person that's like driven to be a flight nurse. If you're that person that's always wanting to learn, take that most complicated patient, you should definitely be thinking about CRNA. They are like, there's type B, there's type A. They're like, what's the next letter? That's them. They're very type A people. They're fun. I don't know that I would want to like one-on-one hang out with one of them because they would probably make me do something scary. I'm perfectly happy to go for a walk around my neighborhood. I live in Utah, but I don't even like hiking anymore. I ran into a rattlesnake and I was like, I'm done with this. I just like looking at houses and, people watching. But they definitely are interesting people to talk to at a party. They're fun. They're interesting. Very smart. But it's very competitive. So make sure you apply to a bunch of places. I think for our program, we have, 500 plus applicants for 30 places or something. But again, don't let that put you off. When I applied to my master's degree, and it was like public health sort of. It was more than that. It's called Health, Population, and Society. The one is called Economics. I think only 10 to 20% of people got in, if that. And I got in. It was my reach. So, always have that reach. And maybe your backup is doing acute care or something. The acute care are very type A. CRNAs are one level up. Psych is, here's why you might want to do psych, not FNP. If you know that you're going to wind up doing psych, but you want to have a backup or something like that, just do the psych anyway, and then you can always go back and top up and do FNP like I did. And let me tell you about topping up. When you top up and get that dual certification, you're going to end up going back and doing 500 extra clinical hours and then however many didactic classes. So for me, I went to University of Cincinnati and it was 4 semesters. I took a lot longer because of personal reasons. My daughter was sick and so it just took me longer, and that was totally fine. They were really flexible with it, but 500 credit hours or 500 hours of clinical experience. And it's a lot when you're working. It doesn't sound like a lot because you're like, well, how much did I do for school? It's a lot. But when I've seen people that work in that have FNP that go and work in psych, and don't do that. If you have an FNP and you see a psych job that will take FNP, don't go work that job. And here's why. A couple reasons. A lot of states, if you have that PMHNP qualification and you're willing to go work in psychiatric mental health, you will get tax credits or you will get your loans paid off for being a PMHNP and working in that field. Particularly if you work with people that are rural or in disadvantaged urban groups. So that's like you're homeless, you're mentally ill that live in or are incarcerated, any kind of vulnerable group, people that are, urban poor, below the poverty line, something like that, or rural. If you have an FNP, even though you're working in behavioral health, you will not get those grants. You will not get that money. You will also not get paid at the same level as your PMHNP colleagues. So one, don't be that person that goes and undercuts that market. Don't go and work for 115 when a PMHNP who has the qualifications, the education, and has taken that extra step to get that specialization, and they are being monitored because most PMHNPs, like Utah has a independent practice, except for the PMHNPs. They have to be watched for 2,000 hours, I think, or maybe it's 3,000. Don't undercut them because they can get paid 130, 140 plus, and you're undercutting the market, and then you're taking away money for them to pay their loans. That's not cool. But also you're not serving yourself. Like, let's not do that to each other, right? and you're not qualified. Sorry, you're not. It's like when I see people that take the acute care jobs that have FNPs, and sometimes it's baked in, you're not supposed to, and yet they will. That's my stance. That's my opinion on it. And it's also like PMHNPs in acute care. We can't go and work in primary care. So that's it's bad form, but also you're going to be woefully unprepared and you're not going to get that money. So just go and do the PMHNP and then go take those jobs. You'll get more money. It'll be worth it in the end. And your colleague who has the qualifications will not resent you. So that's one reason. Now, other specialties that are out there that you might want to consider if it's your passion, there's pediatric ones, there's primary care pediatrics, there's acute care pediatrics, there's geriatrics, and that is a boom industry. I would highly recommend it. I loved working at the VA. I love geriatric medicine. It's so fun. And I think we're going to see a lot more openings in that area, or even just having that specialty. And then if you want to go into hospice, or if you want to go into cancer, or, you want to go work in the hospital, I think geriatrics is a really great way to go. Midwives, of course. You can also be an FNP, or you can do women's health and work alongside midwives, or specialize in that. So that's something else. I have a friend of mine who I knew from nursing school. She's doing midwifery plus that PMHNP at the same time because she knows, I want to do this. I want to meet this. I see this need because she worked in labor and delivery and she knows this is not being met. Smart. Love it. And what else am I missing? Neonatologists. How could I forget the neonatologists? These people are freaking amazing. And I have to say, for me, the neonatologists were the first NPs that I saw, like, in the ICU doing stuff. And I was like, wow, like, these guys are running the show. What is that job? And does it exist? Not in this setting. Because for me, like, I couldn't. Love the NICU, love my pediatric people. I couldn't. And I appreciate it as someone who had a child who needed that care. Like, I love my pediatric nurses. My heart is, I owe everything to them. But I couldn't do it. But the neonatologist, man, there is something else to watch. And that's kind of one of the things that led me to want to do acute care, because acute care is sort of the adult version of them. Sort of, because neonatologists, they're awesome. They are real badasses. So that's another one. So I am a big fan of looking at those specialties and really, really consider it. Generally speaking, the specialists will get a little more money. The other thing too that I found when I graduated in 2019 was all of us in the acute care program, before we graduated, if we wanted, there was, I think, 2 people who were in a position where they were not applying for jobs because of personal reasons. All of us had job offers before we took our boards, before we graduated in May. We all knew, I'm going to go work here. I had a job offer way in advance. And they held the job for me because I had to get surgery. I had all these things going on. I didn't start till September. It was the day after Labor Day. They held that job for me. They were like, you're the one. And I was like, you're the one. And I still work for them, like it was like speed dating, and you're like, I don't want to go anywhere else like you guys. And so it was great. My friends in the FNP cohort all got jobs, like everybody worked, but they definitely took a lot longer to find their jobs. Some people had job offers, but it was definitely a more trickle process. So some of them were not finding jobs until the end of the year. PMHNP take longer in my experience, but that's because they're looking for the right job. The jobs are out there, but they tend to be a little choosier, and so it's not a bad thing. But they all get jobs and they get paid well. That's the other thing too. Acute care, we not only got jobs, had jobs lined up, we were getting paid or getting job offers at that time that were like 10, 15K higher than our FNP cohort people. And the PMHNP people were getting paid about the same as us. I feel like that's changed. And now the PMHNP people are probably getting paid 5,000 more, 10,000 more than the acute care, the potential for earning for the PMHNP people, their ceiling is a lot higher. They can keep earning than acute care, but acute care can still earn more than a family practice person. Their ceiling is a little bit lower. But again, like thinking about going back and doing that cert, my friend is going back now. She did FNP. She makes bank because she works for Big Pharma now, but I think she's looked at what I did with the PMHNP and she's like, yeah, I should do that too. She also worked VA, so she'd be a great fit. But those are my thoughts on it. Those are all the specialties. Drop a question in the bottom if you have any, or any ideas for shows in the future, anything that's burning, especially if you are applying for school. And also answer the question in the bottom, are you thinking about specialty, which one? Because I'd love to know what you guys are thinking about applying for. And thank you for joining me for episode 2.